Thank you to Drs. O'Brien and Grady for their very informative presentations. And I have a few questions that have come in either during registration and online. So I'd like to start, Valerie, if you could say, is there an identifiable strain of H. pylori that is known to be more likely to increase the risk of stomach cancer?
Yes. Oh, is this on? Can you hear me? Yes, so there is. We're starting to learn more about the differences among different H. pylori strains. So this bug is very genetically diverse, and different bugs have different tools that they use to establish infection in the stomach. And the tool that is considered the most clinically relevant is a toxin that is called CAG-A. That is a toxin that the bug actually injects into gastric cells. And once it's inside, it causes a lot of inflammation and damage to the cells, and that can lead to mutations and potentially cancer developing. So we know that people who have CAG-A positive infections are at a greater cancer risk. And we also know that those patients are actually shedding the bug at higher levels in their stool, so they may be spreading it to family members as well.
Thank you. Dr. Grady, I recently became aware of a patient who registered with us, and they are the first in their family to have been identified to have CDH1 mutation, and they did develop stomach cancer from that mutation. But being the first in the family, what recommendations might you make for screening for other family members?
Yeah, so typically what I recommend is when anyone ever gets discovered to have a gene that increases the risk of getting stomach cancer, that the other, what we call at-risk family members, get advised of this and then offered the opportunity to have genetic testing done. And so what do I mean by at-risk? So what I mean are first-degree relatives of that person. So in this particular person, his mom and his dad should get checked, and then if he has any children, and if he has any brothers or sisters. And then depending on what happens with that, then you can check other people in the family.
Okay, great, thank you. And just as a reminder for anybody in the room, if you have questions, raise your hand, and Francesca will be by with the microphone.
Yeah, so I know in the United States you're saying that there's a lower incidence of gastric cancer, but you're also talking about the prevalence of H. pylori being an indicator that you might be prone to develop that. So is there any talk of making, like, there's regular screening now for colon cancer because of a higher incidence of it? Are they talking about making, testing for H. pylori, and then if you're found to that, go on to an EGD to see if you have that chronic inflammation? So is there any talk of doing regular screening for people?
Yeah, so that's a great question, and it gets back to this question of where do you live? And so the reason why I bring that up is, so if we look at people who have H. pylori infection in China, and like for instance, if you go to Vietnam, 9 out of 10 people have H. pylori. So you could almost argue, well, geez, why not just treat everybody? But there's a problem with doing that, and let me tell you what the problem is. So one is that if you start treating everybody with the antibiotics for H. pylori, pretty soon the H. pylori is resistant to that antibiotic. In fact, if we go to certain places where we are doing this, the H. pylori is almost completely resistant to one form of antibiotic called clarithromycin. And so if we have somebody who comes from that area here, we say, boy, we're not even going to bother with that because we know the likelihood of the bug being resistant to that antibiotic is so high. So that's one potential downside to doing just a treat everybody strategy, because pretty soon you won't have anything that works anymore. But the other problem is that there are a lot of people who are infected with H. pylori who do just fine. They don't ever get ulcers. They don't get stomach cancer. In fact, that's most everybody, to tell you the truth. And so the big question that we've wondered then, well, does it really make sense to expose people to the risks of antibiotics? And if we tested at people and then treated them, when we don't know if there's a real benefit from it for most people. And so that's the other challenge. So what we really need to figure out is, so what is it which people are the ones who are the highest risk for getting the ulcers and the stomach cancer if they have the H. pylori. And that's the piece we're still trying to figure out.
So if you tested everyone for H. pylori though, and without starting antibiotic treatment, couldn't you just say, okay, you're potentially at risk, do an EGD for surveillance?
You could, although EGDs aren't risk-free either, right? And so I mean, if we had somebody that was just like totally risk-free, you'd say, sure, do it. But that's the challenge, is that nothing in life is a free lunch. So there are always risks and benefits.
So have they found in these countries where some of them, like Africa, Asia, have the high prevalence of people being positive for it, that if is anyone doing research on sanitation issues? Because there's a lot of sanitation issues in those countries, and since it's oral fecal spread, are they working on maybe sanitation issues, thinking that that might cut down on the positive effects of people carrying it?
Yeah, no, you are absolutely right on. The two biggest things that we could probably do to make the world a healthier place is improve sanitation around the world and just get everybody access to clean water. And the problem is it's so easy to say it. We know it needs to be done, and it just is so difficult to implement that because of the infrastructure and the resources to be able to bring that around. And that's why, the most common cause of death in infants is actually diarrhea. Because in a lot of places in the world, those kids get sick and they're malnourished, and unfortunately they die from that. And if they could just get clean water, that would stop that. Yeah, it's kind of tragic.
Any other questions from the room, in the audience? Okay. I know on your slides, Dr. Grady, you had listed the Braca gene as one of the possible causes of stomach cancer, and we all know it more commonly to cause breast cancer. Do you have anything you could share for those who might be more likely to develop stomach cancer from that gene? Is there anything in their family history that might inform what could happen or what might be more likely to happen for them?
Yes, so that's a great question. And again, because we are doing a lot more genetic testing, particularly in women who've had breast cancer, we are finding more people who have the BRCA1 and BRCA2 gene mutations. And there's a suggestion that there may be an increased risk of getting stomach cancer in some people who have those gene mutations. And what we look for is there anyone else in the family who's had stomach cancer? And what age were they when they got it? Because that, again, the younger you are, the more that suggests a strong genetic cause. And then also considering getting checked for Helicobacter pylori, because this gets back to that, that point of, well, maybe if you have the BRCA1 mutation and H. pylori, you're at higher risk of getting stomach cancer than somebody who just has H. pylori alone, and maybe that person would be the right person to treat.
Thank you. And Valerie, you had also touched on H. pylori treatment when you're identified and diagnosed with gastric cancer. Could you just speak briefly about what recommendations, or maybe Dr. Grady could inform on this as well from the clinical side, what treatments, and does that need to be taken care of first before chemotherapy, or can it be done simultaneously?
Oh yeah, I think I'll have to defer to you on the clinical management question. The treatment is usually just antibiotics, assuming that your bug is sensitive to that clarithromycin antibiotic that Dr. Grady mentioned, which is something we can test in the clinic. We can see if the bug is susceptible or not, and then usually a proton pump inhibitor to limit acid secretion in the stomach, and usually a couple weeks of that is sufficient to cure the infection. But as to when one would do that in a cancer patient, I'm not sure.
Yeah, and so typically the most important issue is actually treating the cancer. It depends a little bit on what type of treatment gets done. I told you about Dr. Tomizawa. Sometimes if the gastric cancer is early and we can do this ESD technique and just take out the particular cancer, that would be our first focus of business and get rid of that. But then we'd want to check for that Helicobacter pylori, and if you have it, we'd want to get rid of that, because otherwise you're at risk for getting another stomach cancer. And so the timing of that would probably come after you had the initial surgical treatment and had a chance to recover and then get treated. Because the impact of getting rid of the H. pylori isn't going to be something that's going to be immediate in terms of your gastric cancer risk. This is something that happens over a long time. Most people who are infected with Helicobacter pylori are infected in their teens. And yet the stomach cancers don't occur until our 60s. So it takes a long time for that Helicobacter pylori to cause that stomach cancer risk. And so it'd be important just to get rid of it so that we prevent another stomach cancer in, let's say, another 5 or 20 years. And so that's the idea behind it. And as Valerie mentioned, it's typically a 3 antibiotic or 3 medication strategy for a couple of weeks to get rid of it. That include amoxicillin, which is a form of penicillin, clarithromycin, and what we call a proton pump inhibitor like Prilosec or omeprazole. But there are lots of different combinations that we can use. And so sometimes we treat people, then we always check to make sure at the end that we got rid of it. And if it's still there, then we want to treat, but with a different type of antibiotics. And there are probably about maybe 150 different group combinations that we use, but we always have to use more than one. So that's one of the key things, is that we have to use lots of different ones. And fortunately, we got some that are pretty well tolerated, because the first type of treatment that we had for Helicobacter pylori was really hard to take, and most people couldn't take the whole combination, so a lot of times we were getting treatment failures. So we do a better job with it now. And if you're one of those people who's really sensitive to antibiotics, we even have some alternative approaches that can get used, and I can tell you about that. There's some data to say that Oregon grape root extract is effective for treating Helicobacter pylori.
Thank you. The last question that came in during the registration was actually related to proton pump inhibitors, so I'm glad that you brought that up. It's a nice segue. Do proton pump inhibitors influence the growth of H. pylori or the development of gastric cancer? And I will open that to either one of you to answer.
As to the growth of H. pylori, we know that the bug, in the decades that it's in the stomach causing inflammation, causes damage to some of the different cell types in the stomach, including the cells that make stomach acid. So over time, those cells die off, and then the pH of the stomach actually raises a bit. So the stomach is supposed to have a low pH, which helps you break down the food. And H. pylori is actually able to withstand that low pH by neutralizing the acid that's surrounding it. But then as those acid-producing cells die off, the pH raises over time. So the second part was about cancer risk, so maybe Dr. Grady could address that.
Yeah, so sure. So all those medicines for treating heartburn, all the PPIs, so omeprazole and pantoprazole and lansoprazole, none of those are associated with an increased or decreased risk of stomach cancer. There are a couple medications that are associated with it, though, and mainly with a decreased risk. And so one of them is aspirin. And all the medicines that are kind of like aspirin for treating joint pain, like ibuprofen. And then the other one is hormone replacement therapy. And we think that we've always wondered if estrogens are protective against gastric cancer, because we see less stomach cancer in women than we do in men. But so if you're taking aspirin for preventing heart disease, it's probably actually a win-win, because it may also help prevent gastric cancer. But we don't recommend just taking it by itself, because aspirin has a risk of actually causing ulcers and causing strokes. And so there's, again, that risk-benefit thing. So we're not confident enough to recommend it alone for preventing gastric cancer, but there's some data to say that it can prevent gastric cancer.
And I think
Sure.
if we have another question in the audience, we'll bring the microphone just so everyone on the webcast can hear you as well.
Just along that line then, so say something like blood pressure medication, there's that one branch of blood pressure medication that was, the study came out or something that it could and there was a recall because it could be causing cancer. Is that something that affects stomach or just?
Do you remember which medication it was?
I think it began with a V.
Vioxx, perhaps? Not a blood pressure medication, but the COX inhibitor Vioxx.
Yeah,
That
well-
had a stroke risk.
And a heart disease risk, but not a cancer risk. But you're talking about a medication with a cancer risk, is that
That was my
right?
understanding. It was,
Yeah.
and I wish I could
Okay.
recall what that was called, but
Okay. Yeah, if you think of it, yeah, because unfortunately I can't speak intelligently to that. Yeah, I haven't heard about that risk. Sometimes one of the challenges is that even though the risk is higher, it's still pretty small. Like it's because they're, I don't know if any of you ever took Celebrex or Vioxx. Those are medicines that were kind of a safe form of aspirin for people with joint pain. And it's associated with an increased risk for heart attacks, but mainly in people who have a history of heart attacks, and also the risk is still pretty low. But if you look at a large number of people, ultimately somebody's going to get a heart attack caused by that type of medication. So that was taken off the market several years ago.
Okay, thank you. Any other questions? Okay, well, I'd like to thank Drs. Grady and O'Brien for sharing their knowledge and presentations with us and answering the questions, and thank you for being with us today.
Thank you.